ahead and get started. I know some people will be trickling in. I'm going to go ahead and share my screen here. Is that something everybody can see? I'm not able to check the chat, so if anybody can kind of just shout out if they can see that or not, that'd be great.
Yep.
Awesome. Thank you. Cool. Okay, great. So as Rhea said, my name is Dr. Sarah Fox, and I'm going to be presenting on transference and countertransference today. So before we get into things, we're going to just talk about any conflicts of interest to disclose. So essentially, neither myself nor Affinity CE and TCN have any conflicts of interest to disclose, and we adhere to ACCME standards for integrity, independence, and accredited continuing education. Okay. So very briefly, I want to introduce myself. As I said, my name is Sarah Fox, pronouns are she, her. I work at New Directions as a clinical psychologist in Pittsburgh, Pennsylvania. I primarily work with adults with a wide variety of presenting concerns. And in addition to that, I also work as a clinical supervisor for individuals working towards licensure. As you'll kind of maybe see from this presentation, I practice primarily from a dynamic perspective, but I also integrate other modalities into my work, including emotion-focused therapy, CBT, ACT, all that great stuff. Prior to doing the work I do now here at New Directions, I've also been involved in college counseling, forensic assessment and therapy, as well as in behavioral health. Okay. So as I said, we kind of have a pretty action-packed hour together, so I'm going to dive right into it. But that being said, I do want to say that I am very open to questions. My goal is to leave some time for questions at the end. But if something comes up as we go and you're not understanding something or you want to clarify, raise your hand. I can kind of call on you, or, Ray can check the chat if there's anything in there, and Ray, please feel free to interrupt me at any time and throw a question out there. So I'm super open to that, but we'll go ahead and dive right in. So let's kind of talk about what our training objective, what our goals are here today that we're hoping to accomplish by the end of this hour. So first and foremost, we're wanting to define current and historical understandings of transference and countertransference. We're also to understand how we use transference and countertransference in our work clinically to help benefit our clients. We're going to work on defining cyclical maladaptive patterns, what that is, understanding how to identify those in our clients, noticing when we're getting hooked into the CMP. We're also going to work on differentiating countertransference that is related to our client's CMP versus countertransference that's related to some of our own unresolved inner conflict. We're also going to be understanding and applying this idea that we create new understanding and new experiences of our clients' cyclical maladaptive patterns to create change. And finally, we're going to be wanting to just understand and be able to manage the different challenges that may come up with transference and countertransference. I know that the vernacular of all this is kind of wordy and seems a bit intimidating, but it's really a lot simpler than it seems. And we'll kind of go through it all together, okay? So first things first, let's kind of all get on the same page about what transference and countertransference are. So we're going to look historically at what it has been kind of understood as in the past and how we can use it today and how we're going to talk about it in the context of this presentation. So if we go back to Freud's understanding of transference, Freud would say that transference is a projection of one's feelings and desires towards another person, often a parent, onto the therapist, right? So Freud saw transference as very natural and inevitable, and he believed that it almost always stemmed from unresolved childhood conflict. Okay, this is not terribly different from how we see transference today. An example of transference from Freud's perspective might be if we had a client who had a very cold and domineering mother, and they learned to cope with her by being overly eager to please and solicit this. You may find them treating you as the therapist that way, right? They may be being overly eager to please you. Okay, so that would be an example of how you see that come up. Freud had a less favorable view of countertransference. So he would have said that countertransference is the therapist's unconscious reaction to the client's transference. It stems from the therapist's own unresolved inner conflict and is a barrier to treatment. Okay, so he saw this as a pretty negative thing. Freud actually said that all analysts would need to go through their own psychoanalysis to sort of root out this countertransference and find ways to manage it and resolve it so that it doesn't kind of present in a therapy context. As you're going to see in this presentation, in a more modern approach, it doesn't really have to be this way. Countertransference can actually be an incredibly helpful clinical tool that we can use to help our clients. Okay. So when we're looking at transference and countertransference in more of a modern lens, as we're going to be using it and defining it today, we would say it's the same dysfunctional pattern that they interact with significant others in their lives, and it's causing them distress. So this is not tremendously different from how Freud saw it. Freud thought it was pretty much almost always focused on that childhood conflict. Of course, that can happen. As we know, childhood is it's a time rife for developing interpersonal dynamics and attachment, but it's not the only time, right? We develop and change our attachment styles throughout the lifespan, so it can be at any time. But that's kind of how we're understanding transference today. So countertransference, on the other hand, is the therapist's emotional reactions, thoughts, or feelings towards a client. And these can be conscious or unconscious, and they come in two very broad forms. So first type of countertransference is the reaction to the client's transference, right? And so what I mean by this, let's go back to that example of the client that had that cold, domineering mother, tends to be overly eager to please and solicitous towards others. If I'm their therapist, I may have a reaction to this in some way, right? Maybe because they're so eager to please me and kind of want to do whatever suggestions I have, maybe I become overly didactic and with them in terms of what we do in therapy. Alternatively, sometimes when people are too eager to please, they can kind of like turn others off them or push them away. So as their therapist, I might even notice that, like kind of feeling like, why is this person so solicitous, so eager to please, right? And that's my countertransference, my reaction to them, right? And this is going to be a normal reaction that other people in my shoes probably would be feeling, and other people's lives probably are feeling, and we'll look for evidence of this. This is this type of really useful countertransference that we're going to be able to use to help the client create progress. The second type is that kind of countertransference that Freud was warning us about, right? And that's projections of the therapist's unresolved internal issues onto the client. And there's nothing wrong or bad about this. Again, it's kind of inevitable. We're human beings. It's going to happen. But it is something that we're just going to want to be aware of, talk about in supervision, maybe in our own therapy, our own reflection, and work through it. It's not really something we're going to bring into the therapy context because it's not something that's going to help us create change for our client. So again, a quick comment here on like the vernacular. I know transference and countertransference can be kind of clunky and get mixed up quite a lot. You'll hear me mix them up in the presentation, I'm sure. But just try to remember, transference is the client's stuff being projected onto the therapist, and then countertransference is the therapist's reaction to the client's stuff. Okay. So now that we have a general overview of what transference and countertransference are definitionally, let's look at maybe some more vivid examples to drive the point home. And these are examples from real life cases that I've had. And you can also kind of try to think and reflect, do you relate to anything in these examples? Have you had clients that have presented in similar ways or different ways? Okay. So the first example I have for you of transference is a client that I had seen. This is in our first meeting, this story I'm going to tell you. And she was a young woman in her late 20s. And she came in and she was very friendly and nice. She was easy to connect with. And she had been going through a lot. She had recently had a miscarriage. She was dealing with some family stress. There was a lot going on for her. I noticed right away, as she was telling me these really difficult, painful experiences she was having of late, she just had a pretty happy-go-lucky look on her face. Like, if you pressed mute on our conversation and just observed us, you would have thought that she was like catching up with a friend over coffee, just on like regular life stuff, right? So that kind of stood out to me, like, something's going on here. The other thing that stood out to me when I first met her was that this was my last appointment of the day. So it was like a 6 p.m. appointment. So we're going to be done at 7. And as I said, she was super friendly and nice, and she was complimentary to me. Thank you so much for meeting with me. And, mental health is such great work. You do such great work. And she had made the comment a couple times, like, oh my gosh, I'm so sorry you have to work so late. Like, oh, I'm making you meet so late. That must suck. They have to work till 7. Really, like, worried about me working too late, or just trying to empathize that must suck for me, basically. And so what I was already starting to get clued into, and what became even more clear later as we continued to work together, was that she had this pattern, this cyclical maladaptive pattern, and we'll get into it later, but this pattern of sort of not dealing with her emotions, or not taking a lot of space for herself and her needs, by either putting a mask on, right, kind of acting like it was all good, even though it was quite heavy. So that was one way she avoided it. The other way she avoided it was by focusing on other people, right? She was a medical professional, she was a carer, so that was very natural for her to focus on others. And just right off the bat from that first initial meeting, I could see that playing out with me, right? So she was kind of wearing a mask, and she was focusing more on me and being worried about me, even as her therapist, than herself. And, we'll talk about this a little bit later. You kind of have to use your clinical judgment. But because we had some nice rapport, because she was so friendly and nice, and we were able to connect pretty well off the bat, I decided to actually kind of name some of these things even in our first appointment. I had kind of named to her, you're telling me these things that are so heavy and like impactful, and I'm feeling with you, but you kind of have a smile on your face. Like, what do you notice about that, right? It's almost like the music and the lyrics don't match, right? You have these really intense sad lyrics, but the music that's paired with them is like elevator music, right? So I kind of called that out to her. I also named, when she talked about like worrying for me that I was working so late, that, I said something like, wow, that must be really hard. You come to therapy, which is like supposed to be a space for you, and you're more kind of worried about your therapy experience than your own. That's hard. Just kind of pointing that stuff out to her, right? And in the end, I think it actually worked out, kind of added to the rapport, and helped us really start off doing some good work and some good awareness. So that's one example of transference. Another example of transference that I can give you that kind of came up was with a client that I had been working with for quite some time. This client had a pretty significant history of trauma, pretty significant depressive symptoms, and high risk suicidality wise. And she was going through a pretty rough patch where the depression was really intense. And even though she had a pretty high baseline level of risk with SI, it was getting even higher than that. So I was getting a little concerned. Can we really manage this at an outpatient level safely? So I had brought up to her this idea of potentially exploring IOP for a little bit. And I made it very clear I would help her get connected to IOP. I could, check in with her periodically, like just the email here or there to see how she was doing while she was in IOP. And then afterwards, we would continue our work together. And pretty much as soon as I said IOP, she shut down. She withdrew emotionally. She kind of got this blank look on her face. She had a really hard time communicating with me. And eventually, when she was able to communicate with me, she told me that she felt that I was giving up on her, that I was basically communicating to her that she was too much for me. Like, hey, you're too much. You got to go to IOP. And of course, as her clinician, as a caregiver, I was just, I was gutted. I was like, oh my gosh, like I did not want to make her feel this way. That was not my intent at all. What did I do wrong? What did I say wrong? Right. But with some time, with some good supervision, some time to process, I realized that this was actually a transference reaction, right? So this client had a pretty significant history of being let down by people, being too much for people. There was this fear of being abandoned, of being left, and all of those fears were getting projected onto me. Because in reality, what I was saying to her was, hey, I care about you and your safety enough that I want to pursue this harder option, even though it's not really what we want. I was communicating to her that I'd be there with her every step of the way. But again, she was having this transference reaction that was being put onto me in the moment, right? And ultimately, we were able to work through it, and that rupture repair actually created a new positive experience for her. But that's an example of transference as well. Before I get into some countertransference examples, I just want to check in real briefly. Any questions coming up, anything in the chat, any clarification I can help with? Okay.
There hasn't been anything, but if anyone has anything that they add.
Yep, cool. All right, so we'll keep moving right along, but yeah, feel free to pop anything in there as we go. So now that we have an idea of transference, right, the client projecting things onto us, now we want to think about countertransference. And again, we have those two types. That one that is this really helpful therapeutic tool that is us responding to the client's transference. And then that other type of countertransference that is inevitable, but is more about us and our own unresolved issues and not so much about the client and not so much what we're going to use therapeutically as a tool. So I have one case that I'll share with you, and I experienced both types of countertransference in this work with this client. So I started working with this client who was a young man. He was a senior in high school when I first started working with him. Smart kid, but he was really not engaged in therapy, not engaged in school, not engaged at home, not engaged in his life. He was putting in minimal effort. He was really not performing to his potential. And therapy was no different, right? I would ask him questions and he would just say, I don't know, efforts to sit with the silence, to kind of push him past, I don't know, to think a little bit more, were not met with much success. And I came to realize, like, I was getting frustrated as his clinician, and I started working too hard, right? I was over functioning for him to try to get some momentum, to try to get some progress. And I realized other people in his life were doing this too, right? The more he sat back, the more other people tried to jump in, right? So his mom was really over functioning for him and doing too much for him. And he didn't have a lot of accountability or pressure to act for himself. Teachers were the same way. They were offering to stay after school, to tutor him. They saw this potential he had. But he wasn't taking advantage of it. And he was sometimes showing up, but not actually being engaged in doing the work. So all of these people in his life were responding to his pattern, his transference of sitting back and withdrawing from life and underperforming. They were responding to it by jumping in and trying to over function for him, myself included. And his teachers, his family, myself were frustrated by this, right? So this was that type of countertransference that I mentioned first. That's very useful. I was experiencing what it was like to sit with him the way that other people in his life were doing, and I could understand it in that way. Now, I also experienced the other type of countertransference towards him that was related to some of my own unresolved issues, right? And that really was my frustration. So as I said, everybody was frustrated with him. So that was not unique to me. But I started to realize that my level of frustration was probably higher, a little more intense than other people around him, right? And so I had to ask myself, why am I getting so frustrated with him, right? And to the point where I felt like it was impacting my ability to be as fully present with him in sessions as I wanted to, right? So, I got some supervision, I did some reflection, I realized he was clashing against some of my values around hard work, self-determination, things like that. I also was realizing he was reminding me of certain family members I have that have displayed some of these similar behaviors in the past that has been difficult or frustrating for me to manage on a personal level. So I realized, again, my own unprocessed or unresolved stuff, it wasn't causing my frustration, but it was causing my frustration to be amplified to a level that wasn't super beneficial to the therapeutic process. So got some supervision on that, found some empathy, found ways to resolve that. But that's an example of how sometimes both types of countertransference can be present for us in one case. Okay. So now that we have a sense of vivid examples of transference and countertransference and how we're going to define them, now let's figure out, okay, what can we do with this information? How can we use it? So you've heard me reference already this idea of a cyclical maladaptive pattern, or a CMP. Okay, so transference and countertransference are going to help us identify and address this CMP. Now, what is the CMP? The CMP is a vicious cycle of how an individual relates to themselves and others that's causing some sort of a dysfunction in their lives, right? So let's go back to this example I just gave of the high school senior. He was overwhelmed by his life, by the demands of life. And so he was trying to cope with this by withdrawing, right? And to a degree, it was kind of working, because when he would withdraw like this, other people in his life, parents, me, teachers, would kind of try to jump in and help him and overfunction for him. But ultimately, it was dysfunctional because it was harming those relationships. People were getting frustrated with him. And it wasn't actually allowing him to gain confidence in himself, to gain skills, to work through the distress of life rather than withdrawing from it, right? So that's the way in which his CMP was dysfunctional for him. Now, we're all multifaceted human beings, and so we all have multiple CMPs. But in terms of finding a focus for our work, especially if it's time limited in some way, it can be helpful to select the most prominent or the most detrimental CMP to focus on for the client. That's not to say we can't address other patterns that are not helpful, but I find that it's helpful to have like a primary one that is the guide for your work. And CMPs include a couple different facets. They include the client's thoughts, feelings, wishes, and behaviors within their interpersonal relationships. It's about how the client expects others to treat them in relationships and how people actually treat them, so expectation versus reality. And then it's also about the client's behaviors, attitudes, and feelings towards themselves in the context of relationships. So how do they view themselves? Do they think I'm someone that is friendly and nice and people want to be friends with? Or do I view myself as someone who is awkward, or, people never seem to like me, stuff like that. So now that we kind of have a sense of what the CMP is, how do we identify the CMP for our client, and how do we understand how it functions and works? So first and foremost, I find it super helpful to let the client tell their own story in their own words. And I listen for themes of how they're engaging in relationships in the past and in the present, right? Their expectations of how people are going to treat them, how they've actually been treated, and how they treat themselves. We also want to notice the push and pull of transference and our own countertransference, right? And this is where that kind of comes into play. So again, transference is that reenactment of a dysfunctional dynamic in the therapy relationship, and countertransference is our reaction to it. So this is going to give me really great clues into how others are probably responding to them, right? So for example, if I have a client that is overly superficial with me in session, like I can't get deeper, I might find myself feeling a bit bored or detached when I meet with them, right? And I can get curious, like, well, why would I feel that way? Like, I'm a caring clinician. I have positive regard for them. So why do I feel that way, right? And that can give me this clue of like, well, maybe other people feel this way when they're talking to the client. The client says that they struggle to develop meaningful relationships, but they're not getting much, right? And I don't feel connected to them. So probably other people wouldn't feel connected to them either. I like to think of countertransference as this really sensitive compass almost into interactions that would be helpful to explore. When I notice countertransference coming up to myself, to me, that's my compass pointing to something, saying, hey, something interesting is going on here. Let's explore that a little bit more. And part of the push and pull of transference and countertransference is allowing ourselves temporarily to get hooked into this dysfunctional dynamic with the clients, right? So I definitely got hooked into that dysfunctional dynamic with that high school student I was naming. Right, I was behaving a similar way that his parents and his teachers were behaving. And it would not have been productive if I stayed stuck in that dynamic with him, but allowing myself to initially get hooked into it allowed me to experience the client in a way that other people did in his life. And that gave me valuable information and ultimately, helped me do some work with him around how to create some new experiences and try to push for a different way of engaging with people around him. Okay. So now we know what transference is, countertransference, the CMP, all those great big fancy words. So now we put it all together to see how we can create change. So it is as simple and as complicated as this equation that we have here. New understanding plus new experience creates change for our clients. Okay, and so I'll tell you what I mean by this. When I say new understanding, what I mean is that we are helping the client gain awareness of their cyclical maladaptive pattern. And we can do this by helping them explore other relationships, how the CMP is present in other relationships. But it's most powerful if we can show them the CMP at play in the here and now between ourselves and them, right? And so we can do this by bringing their awareness to it with here and now statements or process comments, right? So this would sound like, if I had a client that was struggling, their CMP was that they struggle to be vulnerable. I might say, hey, you just shared something really vulnerable with me. I'm wondering what that was like to share, right? And they might say, it was super uncomfortable. I didn't like it, right? So just bring some awareness to the fact that that's hard for them, right? Or I might say, I noticed that when I leaned in and I said something empathetic to you, you almost looked uncomfortable. Tell me what was going on for you in that moment. They might say, yeah, I was uncomfortable. Like I haven't really gotten a lot of empathy in my life, so I don't know how to take it. It's kind of strange for me, right? It's new. Another example of a process comment might be, last session, you were so open, you were so vulnerable with me. I really appreciated that. I felt so connected to you in work. But I'm noticing today you almost seem a bit, I don't know, withdrawn or closed off. What do you think's going on? Right. So I might be raising awareness to them that they have a pattern of maybe leaning in and then leaning back and kind of closing up again. Okay. So that is that new understanding, getting them to realize, hey, like I am kind of stuck in this dysfunctional pattern. Then from there, we have to create a new experience for them. So we want to create a new, more functional way of interacting with others. So we want to see them behave differently and emotionally appreciate what it's like for them to behave differently. And again, we can do this here. Me, take a chance, be brave, engage differently with me than they typically would with somebody. And if they can experience, hey, good things actually happen when I'm vulnerable. I get positive feedback, or I feel more connected to people around me, or whatever it may be, or I don't get rejected, things like that. If they can do that with me in the safe space of therapy, then we can branch out and we can have them start creating new experiences outside of therapy as well, right? What happens in the therapy dyad between the client and the therapist is like a little microcosm of what happens outside of therapy, right? And therapy is a safe space because, of course, it's completely confidential. You have unconditional positive regard for them. They're not going to see you outside of therapy. They're only in your life that 1 hour a week or whatever it is. So it's a safer space to start. Okay. So when we think about new understanding and new experience creating change, I like to always kind of think about it in terms of like a menu analogy. So new understanding is kind of reading the menu. Oh, do we have a question, or maybe somebody's unmuted? Okay. Yeah, feel free to pop up if you do have a question, but we'll keep moving right along. So this menu analogy, new understanding is kind of like reading the menu at a restaurant, right? It's interesting, it's great, it's necessary to create change, to get your food to order, but reading the menu in and of itself is not sufficient, right? It's eating the food that fills you up. It's eating the food that's the new experience and ultimately creates that change, right? And this is a good thing to be aware of, especially when we do this type of insight-oriented work. I love that kind of work. I love an aha moment as much as anybody. It's so gratifying for us as therapists, right, to create this new understanding for our clients. But we don't want to spend too much of our time in the new understanding zone, because ultimately the new experience is that active ingredient that creates change for our clients. So that's where we want to be spending most of our time. Okay. So now let's talk a little bit about just managing transference and countertransference and what that can look like. So we want to be able to tell as clinicians when we are in that transference and countertransference dance, right? So if you've ever gone dancing, if you've been the leader or the follower in dance, it's very similar to that, right? They move and you move to compensate, right? And so we're always in this interpersonal dance with other people. And in therapy, we identify the dance and then we figure out what moves we need to change to make it more functional for the client, right? So we need to know that we're in the dance. So how do we do that? So one way is do supervision, right? Supervision is awesome. I love it. I can't recommend it enough, right? Even after we're licensed, as much as we can get it, because when we're in the dance, sometimes we're too close to see what's happening, right? So having a third person that's outside of the therapy dyad help you identify what could be going on is invaluable. Another good question to ask yourself is, am I responding differently to this client than I would typically? So again, we can go back to that example where I was overfunctioning for a client. Typically, the way I approach therapy is I will meet you effort for effort. Like I will work just as hard as you, but I can't work harder than you, right? That's kind of one of the tenets of which I, guide myself in therapy, because I feel like the client has to have some ownership there. So when I start over functioning for a client like that, I'm like, oh yeah, something's going on here, because that's so out of character for me, right? Why am I being pulled to do this thing that's not typical? And you can also think about your own kind of personal tells, so that's one for me, is whenever I'm over functioning for the client or working too hard. Another one for me is if I'm spending a lot of time in supervision on the same client again and again, that's a good sign there could be some transference, countertransference going on. Another thing I'll notice is typically in my work with clients, there's a flow to it. I feel very present. I feel very engaged. And when I don't feel present, or when it feels super effortful, like in a hard way, almost to the point of like, I feel like I'm straining my mind, that's a good personal tell for me that there's probably something going on here. There's probably some transference or countertransference pattern that I've not yet identified. And it's also really helpful to ask yourself a question to help differentiate between that helpful type of countertransference we discussed and the type that is not as helpful and that we're just going to want to manage outside of the therapy context, right? So ask yourself, would another reasonable person respond to this client in the same way that I am, right? That's a really good litmus test to try. Because if I feel like, yeah, most people would be annoyed, or most people would be frustrated, or most people would feel whatever I'm feeling, that's some evidence that it's probably that more positive kind of countertransference. If I'm like, no, I don't think other people would feel the same way as me, I think this is a little unique to me, that's good information that it may be that other type of countertransference that's due to some unresolved stuff within myself. Okay. So we're also going to talk about some different types of transference that we may see come up in our work with clients. So very broadly, we can have positive transference or negative transference. And again, as a reminder, this is the client projecting things onto us. So positive transference is when these like positive aspects of previous relationships or experiences get projected onto us. So if we remind them of a teacher that they really liked, or a coach that was really encouraging to them, or even like the parent of a friend who was really nice to them, we're going to benefit from some of this positive transference. We can also experience the flip side of the coin, that negative transference. So maybe, as much as we try to break down power dynamics in therapy, they are inherent. So maybe they see us as a authority figure, right? So they may project some of that negative feeling towards authority figures onto us. This is even further complicated if we're doing like forensic work, where it really is like a court mandated situation. Or if we remind them of a parent or something like that, right? Working with kids, like if they're just see us as like this, we're just another adult that's making them do something they don't want to do, right? Beyond the broadly positive and negative transference, there's a couple different types of transference we might see come up. And this is not an exhaustive list by any means, but these are some common themes we may see. So you may see a parent-child dynamic come up where they're almost treating you like their parent, like you're the one in charge. They may be treating you like a friend because they don't really know any other connect with people. You may see this like submissive and dominant dynamic come up where it's like anything you say, they treat it as like gospel and they do it. This can be a tricky one because we, in some ways, we're going to like this as a therapist, obviously, like, yes, they love my homework assignments. They always do them. Awesome. But we want to be mindful here because we want to make sure that they feel comfortable disagreeing with us, that this isn't part of their maladaptive pattern. They just are overly solicitous to people. Again, look to attachment figures. They may project some of those feelings towards attachment figures onto us. That's very common. Another type of transference I want to talk about, especially because I feel like it can be kind of stressful or scary for us as therapists, is erotic transference. So erotic transference is something that occurs when the transference becomes sexualized or romanticized in some way, right? So the client believing that they're in love with their therapist or having sexual fantasies about them, right? This can be very scary for clinicians to manage, but ultimately, when it's well managed, it can be so productive for therapy, right? So, of course, in this discussion, we are working off of the assumption that we are all wonderful, ethical clinicians, as I know we all are. And so, of course, we haven't done anything to bring this on. We haven't been engaging inappropriately or crossing boundaries or anything of the sort, right? And yet, our client tells us that they're having this erotic transference with us. So we can kind of consider, well, why might this happen, right? And there's many, many reasons why erotic transference can occur. So a couple examples would be, for example, maybe a client is used to always sexualizing relationships in order to gain favor. That's how they engage with people, and they like you, they want you to like them, so it's become sexualized to them. The other thing that can sometimes happen is that as a therapist, we provide this unconditional positive regard. And if they have never benefited from mutual love, from genuine back and forth connection, they may mistake unconditional positive regard for genuine love and care, even though it is a completely separate thing, right? Another thing that can sometimes happen is that the therapist, in some ways, is kind of seen as this like untouchable object. It's somewhere in their subconscious. They know this is never going to go anywhere. My therapist is never going to reciprocate or be in love back with me or anything like that. So in some ways, it can feel almost safer to make the therapist become like the love object in their mind, rather than pursuing someone that they could actually have, but which would be scarier, more vulnerable, more risky, right? And so, as I said, when managed well, great things can happen here, right? So we can just thank our clients for being so brave to share some of these things with us. And then we can kind of process and talk to them about what's going on, right? Like, maybe we can give them some information about boundaries, right? And about like the ethics and the power dynamics at play in therapy. And we can also use this as an opportunity to kind of give them some information about genuine mutual connection, right? It's like, you may think you love me, but at the end of the day, you don't really know me, right? Like, you don't know my hobbies and interests. You don't know my family. You don't know my annoying quirks that drive my spouse nuts. It's inherently somewhat of a one-sided relationship. And that one-sided relationships that have power dynamics baked in, that can never be genuine mutual love, right? Or we kind of talk about, why are you putting so much of your energy on this fantasy of a relationship that will never be? Is there a different kind of relationship that you're avoiding engaging with out of fear, right? So this can be such useful information and so productive for therapy, right? So I just want to spend a little bit of time on that to take some of the stress out of it. But again, anytime there is erotic transference coming up, get really good supervision. That's so, so important. I will also say, just as a real quick reminder, any kind of erotic countertransference, like any feelings that you have towards the client, they need to be super promptly identified, managed, and supervision. They may require you to transfer client care. Erotic countertransference is never something that's going to be brought into the therapy to discuss with a client ever. But erotic transference, the client onto us, that can be a productive thing to explore. So I also want to talk a little bit about the role of self-disclosure in this type of transference, countertransference work, because I know that sometimes that can be a little bit confusing. Like, what are we sharing? What are we not sharing? Excuse me. So this really runs the gamut of focusing, like disclosures that focus pretty much solely on the interaction in therapy, that therapy dyad, all the way down to ones that focus on the self, as in the self is the therapist, right? So process statements or here and now statements that I mentioned before, that's really all about the interaction with the client. So for example, if I say, I noticed that when I said something complimentary to you, you cringed, right? Yeah, I'm disclosing that I noticed that. So I am disclosing something about myself, but it's really all about the interaction in therapy. The second type that moves a little bit to the right is the self-involving response. And this is essentially transference disclosure. So if I say to clients, when you were so open and vulnerable with me, I felt myself being like really connected to you in our work and leaning in towards you, right? So I am disclosing that I felt these warm, positive feelings towards them. But again, it's all about that transference, countertransference therapy dynamic, right? And so this type of transference and countertransference work we're talking about, this type of dynamic work, we're going to be spending almost all of our time in the process statements and the self-involving responses. If we move farther to the right, there is present personal information that we may self-disclose. And this is essentially just information about the therapist's present state. So it's not about the therapy dynamic, but it is something that you choose to tell the client to maintain therapeutic alliance or to prevent regression or worry for the client. So I can share with you a good personal example. I'm about 8 months pregnant now, and so that is something I have been sharing with my clients. Because certainly they're going to notice I start to look different over time, and of course I want them to know that I have a plan for them. I'm going to be out on maternity leave and not have them worry or anything like that. But that's a good example of present personal information. The type of disclosure the farthest to the right is disclosing past behavior or personal feelings. And this is the most focused on the self. So this might be disclosing that you yourself attend an AA, or that you yourself has struggled with anxiety or microaggressions or something of this nature. Different theoretical orientations will be more or less okay with this type of self-disclosure. It's not inherently bad or wrong. I mean, the rationale for many clinicians here is that it can help build rapport, it can help increase client disclosures. We all need to be mindful of boundaries and make sure whatever we're disclosing is in service of the client. But this is another type of disclosure, but it's really not a type of disclosure that in dynamic work you're really going to be doing. Okay. So now I want to talk a little bit as we start to come to the end of our presentation here on fears that we as clinicians may have about using transference and countertransference and addressing them a little bit. So one big fear we have is that, oh my gosh, my client is going to think that I'm criticizing them. And I get that fear, right? If I'm telling a client that they're keeping things surface level with me and so it feels hard to connect with them, that could feel like criticism, right? That can feel like a difficult thing to say. It can almost feel like it's opposed to unconditional positive regard. I take a different approach though. I actually think, how rare is it that we get genuine feedback from people in our lives that's useful? And so I actually find providing that genuine feedback can help build rapport, because they're like, okay, thank you. Like I've always wondered, like, why am I struggling so hard to connect, right? I think it's also is a type of unconditional positive regard, because we're saying, hey, I see all of you. I see the easy parts, I see the hard parts, the parts that are working, the parts that are not, and I accept all of you, right? It's not a criticism, it's not a judgment. I'm seeing you fully. There can also be this fear as clinicians that we're going to lose our neutrality or this blank slate persona, right? The way I see it is that is not a realistic goal, to be completely neutral or to be a complete blank slate, right? Anything we say is a self-disclosure of some kind, right? Of our thoughts, different things like that. So I'm not going to spend any time trying to hold on to this neutral persona. Instead, I'm going to use this really sensitive clinical tool that I have of countertransference to help guide me to help my client make progress. The other fear that often comes up for clinicians is that it's quite vulnerable for us. And I totally agree with this. I remember when I first started experimenting with this type of work in grad school, and it was really vulnerable. Like I can remember feeling so nervous every time I wanted to make a process comment or a here and now statement. But that gets so much better with time. It gets easier as you do it. And the other thing I like to think about is that we ask our clients to show up and be vulnerable with us every single session. So to me, I think, hey, the least I can do is return that and be vulnerable in a way that's beneficial for their progress. The other fear that often comes up is, what if my interpretation of the transference or countertransference is wrong? And to that, I would say it will be wrong sometimes, right? I'm wrong all the time. You know, that's okay. That's inevitable. You know, we want to be discerning with the interpretations we're making, but you're going to be wrong sometimes. I acknowledge that. Like I'll even say to clients, like, hey, I'm kind of wondering if this is what's going on, but tell me if that's not hitting the mark for you. You know, try to come into it with that approach. Finally, a lot of times a barrier can be that we feel bad allowing ourselves to have these like negative reactions or feelings towards our clients, you know, of like allowing myself to acknowledge that maybe I feel kind of bored when I'm talking to this client. And again, like I said, I don't actually see this as in opposition to unconditional positive regard. It's seeing them fully as they are. It's using this internal compass that we have to help them make progress. And it doesn't mean that we don't care. It doesn't mean we don't like them. It doesn't mean we don't see them as valuable and worthy of good things in their life. We're just using a tool that's available to us. A couple quick comments, and then I want to make sure to save time for questions, but a couple quick comments on moments when transference or countertransference maybe is not the most helpful tool to be using, or not right away at least. So we want to make sure there's enough rapport there first. Use your clinical judgment here. You know, you're all wonderful clinicians. I see that evidence, like you're giving up an hour of your day to learn and to grow. So use your clinical judgment on when you think there's enough rapport built up that you can do this. If the client is excessively fragile, if they're narcissistic or easily humiliated or ashamed, there's some extra considerations here. It's not that we can't do this work, but we're gonna have to tread much more lightly, go a lot slower. Again, we don't want to get stuck in this pattern of using too many interpretations or too many of the new understandings rather than primarily new experiences. And again, when countertransference is about our own unresolved issues and not the client's cyclical maladaptive pattern, we don't want to bring that into the therapy space. However, in general, I do want to say we tend to overestimate the negative impact of using transference and countertransference. So it can be scary, but it really doesn't need to be. It can be some great work that you can do with clients, and it's amazing how this experiential work can create some really good change for them. So I do have a case example, but I want to at least pause and give some time for questions. If we don't have any, that's fine. We can return to it, but I want to make sure that we have, you know, at least 10 minutes for us to talk about questions that are coming up, because I know we went through this so quickly. So feel free to raise your hand or just shout out if anything's coming up, or throw in the chat, whatever you're comfortable with. Yeah, Amy. Oh, you're on mute still.
Hi, thank you very much for this presentation. I'm actually a new hire on my first day of training, and everybody left, and I saw this pop up, and I thought, this is a really good conversation to be having, and especially just starting out. I did my internship. I did have one client where he just thought from day one that I was it. I was going to solve everything. And to be honest, he was around my age. We had many similar interests. We loved the same singers and musicians and artists, and we both did photography. So there was a lot actually that was real.
Yeah.
And so I had to walk the line between being real and being authentic, and also not trying to get into the friend zone.
For sure.
Where he wanted me to be, because he knew I was leaving, and he was like, why can't we have coffee? Why can't, and all I could say to him is, I think if we did that, you would not be able to move on and do all the great new things you're going to be doing with the people you're going to be working with after me. I mean, but at the same time, there was this like a little bit, to be honest, a little bit of like this, it actually would have been nice to be friends with this person.
Sure.
So I just want to know, like, as a professional and as I'm a newbie, I would like to be able to handle these situations in a genuine, compassionate way.
Yeah, that's such a great question, right? And I think this comes up a lot with clients because we want to build rapport, right? And so a lot of times we're like, oh, we do have things in common. And at the end of the day, we are two human beings sitting across from each other in a room, right? And so we're going to connect. And to me, the way that I try to handle this is becoming very aware of this early on for myself, right? Of like, I could kind of see myself being friends with this person. That's not a problem, right? But it's something that I want to be aware of and be
Yes.
aware not to lean too much into that friendship side of things. And, very gently and caringly naming it, right? Of like, I think you're awesome. I really like you, but it seems like you're spending time trying to make me a friend rather than maybe doing some of this work. Let's get curious about that. Where's that coming from, right? Like maybe they're struggling with making friends in other contexts or something
Right.
like that.
That's the second part of my question, doctor, is that there was a line toward the end where it says, do not make process statements in the therapy about the transference, countertransference. And so I'm wondering if I misunderstood that.
Yeah, let's look at that because I'm not sure exactly which one you're pointing to. Are you looking at this chart?
And no, I think it was line by line kind of thing that you had.
Okay.
It
So it's not about not making
any
process
process.
comments. Yeah, no,
Okay.
you
It
do
was
want to
about the
make
erotic
those.
thing, and
Oh,
about never, like, don't discuss this with the client.
if you as the therapist are experiencing erotic countertransference, so
Oh,
if
I see.
you are finding yourself
Oh,
having like romantic or sexual feelings toward the client, yeah, no, but in terms of
they're maybe feeling that way, then is it
yeah,
okay to talk about that? I mean, with supervision, I mean, under supervision, of course.
yeah, with
Or
supervision, like
just say, we can't talk about that. That's ridiculous. Like, I don't want somebody to feel humiliated or,
Mhm.
basically, I think he just wanted a friend, but at the same time,
Yeah. So just
I
to
had,
clarify, right? So like you
yeah,
said, you're talking not about this idea of the erotic transference, but that friendship thing, right? And
right.
so we can totally talk about that. That's a good thing to talk about and to
Okay.
name that, right? Of like, I'm noticing you're almost like pulling for me to be your friend, and you're an awesome person. I really like you, right? Like
Mhm.
maybe in a different life we would be friends, but let's talk about that, right? Like,
Right.
what are you getting out of trying to be friends with your therapist? Because I mean, as you know, ethically bounds, we really can't ever be friends.
Right.
And so we're going to get curious in a very caring and positive way
Right.
about why that's happening. So again, maybe he's struggling to make friends outside of like in his outside of therapy in his regular life. And so he's like, wow, you're so nice to me. We do have things in common. Maybe we can be friends, right?
Right.
But
Right.
that's never going to be a functional dynamic because as I said,
Exactly.
it's like he doesn't really know you at the end of the day. He can't really know
Exactly.
you. We want him to have really fulfilling full friendships outside of therapy. So then we figure out, okay, how can we help you do that? What are you struggling with?
Homework assignments. I
Yeah,
had him call you up your old bestie, and next time we meet, I'd love to hear about you having coffee together.
yeah, awesome,
I mean,
great.
I was trying to lean into some strengths that I could see he had, but
Yeah.
was maybe scared to show to other people.
Yeah, for sure. Right.
I,
Yeah. So I think it sounds like you were on the right track, right? If anything, I think maybe there's just sometimes that natural fear we have as clinicians, just as you said, right? We're like, I don't want to make him feel bad or like ashamed that he wants to be my
exactly.
friend. Right. And I
Exactly.
totally get that. But with some practice and with coming at it from a place of compassion and care, which I know that you would, it can actually be really positive, and in some ways the client is like, oh, okay, yeah, like thanks for calling that dynamic out. I actually feel less stressed. Um, so I hope that kind of answers it. So I
It
have a
does. No, it
awesome.
does. And I
Okay.
want to thank you for this. It's been very helpful for me.
Yeah, for sure. So, Mary, I'm going to get to you in 1 second. I also see I have one in the chat from Leah. In my own professional experience, I feel like the number one reason I hear clients terminate with the therapist is due to talking too much about themselves. It's a narrative I hear a lot. Is there any advice for processing this with the client? I always feel like it had a lot to do with transference. Yeah, I mean, a lot of times something I would say that's just generally very helpful, and I found it to be helpful, is just making sure to have some fairly consistent check-ins with clients of like, hey, how do you feel like therapy is going? Are there things that you're not getting out of it that you need? Are there things that you need to be doing differently? Is there anything I'm doing that is helping or it's not really helping you? And kind of creating that space to have that conversation. And sometimes I think what can happen is when we get too far to the right of that little arrow I showed you, where we're kind of using those like self-disclosing disclosures, sometimes that for clients can be a little off-putting. I mean, it really depends on the client and the situation and your style. But I have found that when I'm disclosing countertransference or we're talking about transference, clients tend to respond pretty well to that because ultimately it's really focused on them. But I do recommend just checking in with them regularly. Even when I give a process comment, I always say, how was it to hear me say that? Right? Like sometimes they're like, it kind of pissed me off, right? And that's good information to have. So that's something I would recommend. Mary, thanks for your patience. Yeah, what's your question?
Yeah, I guess I was just curious if your experience or anybody else's, how you've seen this present in younger kids, and how you would handle it differently, if so.
Yeah. And when you say younger kids, what age would you say you're kind of thinking about?
Like 10 and under.
Like 10 and under. Yeah,
Yeah.
I mean, so I will say for me, I'll acknowledge I don't really work with younger kids. And I think the way that I look at it is you have to think about what's developmentally appropriate. Like what can they um, cognitively and emotionally do, right? And so with them, you're probably not going to be able to do a lot of this, like actually talking about the transference and countertransference. But I do think it's helpful to think about like, okay, I'm an adult in their life. This is how they're reacting to me. So maybe they're reacting this way to other people. I'm not like really processing with that with them directly, but that's good information for me, right? So like maybe they're kind of like lumping me in with like their teachers or people like that, or maybe they're lumping me in with authority figures like their parents or whatever, you know. So I'm gaining information from it, but I'm not necessarily, going to be like processing it with them, if that makes sense. I don't know if other people have other thoughts who do more work with kids as well that might want to chime in.
Thank you.
I'm mindful.
I'm so sorry. I was gonna say I can't share because I see a lot of kids and teenagers. It really all depends of your teenager. It really depends on how they read you because I have teenagers that they have experienced multiple therapists in the past and might be close. And so when you are a little bit more transparent, they understand that you're also a clinician, but you also be like, oh, she gets where I'm coming from. Because a lot of teenagers can feel like adults don't really understand me or understand my experiences. So, especially nowadays with things like bullying or social media that maybe it was kind of like present in our lives, but it wasn't as exposed as this generation. That also happens when like I won't necessarily like share like, oh yeah, like back in the day, and I will make it like a joke, like yeah, like I feel old telling you that 15 years ago this was an issue, but I can understand why social media now plays a role thing. Or it was just somebody who's more like logical, I might try to regenerate the statement to more like what they think before how they feel, instead of sharing like, well, an experience at that. But it really all depends on your child. Some children are more superficial because they don't have a lot of they don't trust their adult figures, and so therefore that's when you want to be like, all right, well, we can talk. Sometimes the first couple sections about talking about things that they enjoy and things that they kind of like or don't like, or drama about school, because they always, especially at the beginning of the year, there's like drama with one girl, drama with another girl. So it all depends on your patient and the level of trust that you have within yourself of disclosing certain things. Now, I wouldn't say like, oh yeah, I was victim of a bullying as well, and look, I'm here, because that might be like, side eye. But I will also meet where they are and see what better matches your patient.
Yeah.
That's helpful. Thank you.
Yeah, and I think, you bring up something important too, and with that, it's like, again, even if like they can't necessarily process the transference and countertransference with us, we can still help create a new experience. Like I think you were saying, right, of like, I can be this like stable adult in their life, right? I can kind of model for them that like some adults can be safe, some can be predictable, kind of stuff like that. So I think the same principles apply, but you're just not going to be like processing it necessarily in the same way unless it's developmentally appropriate based on their age and just them as an individual. I am mindful of time. I do really appreciate everybody being here. So it's totally okay if people need to pop off and go see clients or just end their day. But I'm happy to stick around for a little while, and I meant to do this earlier. I'm gonna put my email in the chat. If anybody has any questions and they want to follow up, please feel free. But like I said, I'm happy to stick around for some more questions if anything does come up. Yeah, Elmira. Am I saying that right? I want to make sure I'm getting the name right. Oh, you're muted.
About self-disclosure, many years ago, I have a very interesting interaction with a client that she was initially difficult to engage. And one day in this session, she was complaining, and then she was telling me like, you have no idea what is going to be a Saturday night without a day. You have no idea, but, and I just said, yes, I do.
Mm-hmm.
And I just left it like that.
Mm-hmm. Yeah.
And that was like enough to gain this woman trust.
Mm-hmm.
And we had a good session after that, a lot of good work, but she was claiming something. And I said, yes, I know where you are, because I've been there without having to disclose anything about myself.
Yeah, yeah. I think that's such a great example, right? There's no hard and fast rule with disclosure, because like in that moment, like you said, it was just perfectly done, perfectly timed, and it helped, right? So
Yes.
yeah, great example. Thanks for sharing that.
Yeah.
Thank you so much. That was very informative, and everyone in the chat seems to agree. So, does anyone else have any more questions?
Like I said, if not, or if anything comes up later, feel free to reach out. And you have the link. I think everybody does, and like they said, they'll be emailing out for a certificate for CEs. And then yeah, Ray, I don't know if I think if when you end the meeting, you'll get like the recording and all that good stuff, right?
Yeah.
Okay.
So,
Yeah,
okay.
so people can pop off or stick on, but otherwise I'll wish everybody
Thank you.
great day. Have a great Monday, great week. Thanks so much.